Okay, so should we go?
Yeah.
Oh, okay. So today we're going to talk about Spina Bifida. I'm Casey. I'm Natal.
I'm Meryl.
I'm Kiana.
So Spina Bifida is a Latin term that literally translates to split or open spine, and it is the most common permanently disabling birth defect in the United States. It's classified as a neural tube defect, which occurs when the vertebra, the bones around the spine, do not properly form around the spinal cord. And it happens quite early on in pregnancy. As you can see here, this is at 21 days, and then here by 28 days it has otherwise formed, but there's this gap right here, and that's indicative of Spina Bifida. And this gap can happen anywhere along the spine and can range in severity in terms of complications for the fetus and the baby, and eventually the growing and developing child to adult, depending on the location of the gap and then how large it is. So while there is no definite overarching cause of Spina Bifida, many cases throughout the years have been linked to low levels of folic acid in the early stages of pregnancy for the mother. Folic acid is very key in the development of cells and also in the formation of tissues. And its natural form, folate or vitamin B9, can be found in various foods like leafy greens, asparagus, papaya, and oranges, all great things. But since the 90s, it could also be found in enriched food products like bread and pasta, cereals like that, and that was a response to a 1992 recommendation by the U.S. Public Health Services. They recommended that women of childbearing age increase their consumption of folic acid in order to reduce the incidence rates of Spina Bifida and other neural tube defects. And then in 1996, as a response to that, the FDA implemented an authorization saying that folic acid would, from then on, be in all enriched foods. So you can see here, 1996 is pretty much where this spike is. This is the Spina Bifida rate per 100,000 live births. And after the implementation of folic acid in enriched foods, that level started to decrease, which has led to 600 to 700 babies born without a Spina Bifida defect each year and has saved nearly $500 million a year as well. And both of those are from the CDC. So there are 3 types of Spina Bifida, each having its own set of symptoms. This here is a normal spine. And then this is a spine with Spina Bifida occulta, and occulta translates to hidden. And it's called this because many people who have this type of Spina Bifida don't even know it until they go in to get an imaging test done for an unrelated reason. And then it's revealed to them that they actually have a separation or gap in between one or more of the vertebrae in their spine. And since the spinal nerves aren't really impacted by this at all, it's simply just a gap. There's usually no complications, so there's no treatment necessary for this, although it can sometimes be seen at birth with a little tuft of hair here, or there could be like a misshapen dimple or a birthmark or something like that, and it would be directly above the affected area of the spine, but otherwise it's relatively uncomplicated, and most people don't even know that they have it. The next type is called meningocele, and this is when the meninges of the spine, the dura mater, the arachnoid mater, and the pia mater, they are pushing through this gap that's created, and it creates a hole in the vertebra that creates a fluid-filled sac. And sometimes this can have complications for the fetus and then the growing child if the meningocele is located on a part of the spine where there's like specific nerves. So if it's on an area of the spine that controls bladder function, for example, then the baby, child, growing person might have problems controlling their bladder as a result of this. And then the third type is the most severe, and I think it's mostly what people think of when they think of Spina Bifida. It's definitely what I thought of. I didn't even know that there were 3 types before. It's called myelomeningocele, And that's when both the meninges and the tail end of the spinal cord are going out through that hole and again creating the fluid-filled sac. This can bulge out of the baby's back, and it ranges in size, but they're often pretty large. And sometimes during childbirth, this sac can burst, and when that happens, it directly exposes the spine and its nerves to the elements, which is obviously extremely dangerous. This type of spina bifida often results in some sort of paralysis, usually lower limb, and requires surgery within the first couple of days in order to protect the central nervous system and the affected area from infection.
Spina bifida is most commonly diagnosed in utero, and the first line of testing occurs from 15 to 20 weeks with the maternal synopsis alpha-fetoprotein testing. And in this testing, they take a blood sample from the mother and they test the AFP levels. And that's what AFP looks like over in the left-hand corner. And this is a graph of what a normal level would be. And as you can see, the levels in a patient that presents a neural tube defect, specifically spina bifida, are extremely elevated. And this is the first screening technique, and it tends to catch around 70 to 90% of babies with neural tube defects. But this is only a screening technique, so it can provide false positives. So if a false positive could be caused because the mother could be further along in her pregnancy than she expects, or she could be carrying multiples. Also, AFP is a protein that's produced when someone has a tumor or certain types of cancer. So if the mother has undiagnosed cancer or a tumor, she could be having AFP in her blood unrelated to her pregnancy. So AFP is usually confirmed. The results of the test are normally confirmed via ultrasound. And the ultrasound allows you to visualize spina bifida from the absence of soft tissue. So you can see along the baby's spine here, there's a little black marking, and normally the spine would be continuing, there would be soft tissue, but it's not able to be seen, and so in different view you can see the fluid-filled sac. And then you can confirm this even further with 3D ultrasound, because as you can see, the hole becomes very clear and the fluid-filled sac is very prominent in 3D ultrasound imaging. And then if they have a positive AFP testing, but they aren't able to confirm it via ultrasound, then they do amniocentesis, which is kind of the last step for testing because it's testing of the amniotic fluid. And while it's significantly more definitive, it also poses a lot of risks for the child. So they still are testing for AFP in the amniotic fluid, but improper technique or just having the procedure done can cause early birth and other problems for the baby and the mother, so they try to avoid this if they can. If none of those techniques work, or they opt out of having an amniocentesis and just waiting until birth to be diagnosed, there is postnatal diagnosis. On the top right, that is a case of spina bifida occulta, which you can see from the very small dimpling right there. So that one's not as obvious, but in the more extreme cases, it's a very prominent birth defect that's very visible upon birth. There's a lot of associated complications due to the nature of spina bifida. The most common is hydrocephalus, which is fluid building up on the brain. And this happens because the cerebral aqueduct between the third and fourth ventricle becomes blocked, and the cerebrospinal fluid isn't able to be drained and circulated properly throughout the body. So this causes enlarged ventricles, which build up pressure within the brain because the dura mater doesn't allow for much stretching. Along with this, a brain malformation that often occurs along with hydrocephalus is Chiari malformation type 2. And this is when the cerebellum becomes enlarged, and the cerebellum and the spinal cord both start to descend into the foramen magnum. So this graphic shows the enlarged cerebellum, and specifically the vermis is normally what descends through the foramen magnum. And in this scan, this also causes hydrocephalus because, as you can see, the cerebral aqueduct is completely blocked, and you can't really distinguish it at all in someone that has Chiari malformation type 2. And then by far the most common is nerve damage, and this happens because, as Casey explained, the spinal cord goes into the fluid-filled sac, and that causes nerve damage to wherever the malformation occurred. The nerves below that are damaged, and this can cause paralysis, bladder issues, and just a lot of fine motor skill issues with the child.
Spina bifida has been around for a very long time, and for most of the time, like about 9,000 years, people just really didn't know what it was and how to treat it until Dutch anatomists came across it and identified it in 1610. Dr. Forest did the first surgical procedure on Spina Bifida, but he was unsuccessful. And a few years later, another Dutch anatomist, Dr. Nicolaas Tulp, wrote the first actual book about Spina Bifida, and he described his surgery in detail, and his surgery was unsuccessful too. So for a long time after that, for about 2 decades, people just thought of Spina Bifida as a fatal disease, and they didn't think there would be any treatment for it. For example, Dr. Benjamin Bell said every attempt of this kind of treatment should be avoided, for hitherto the practice has uniformly proved unsuccessful. So they just didn't have any hope on future treatments. And another decade later, Dr. James Morton did find some treatment. It was not an actual surgery, but found that you could insert the sac with an iodine glycerin injection, and that helped relieve some pressure and improved the situation of a lot of children with Spina Bifida. And another, 4 years later, Dr. Charles Fraser did the first successful surgery on Spina Bifida and he published his work in Surgery of the Spine and Spinal Cord in 1910. And from 1910, people actually had hope for Spina Bifida as a disease that could be treated. And in the 20th and 21st century, treatments for this disease developed further, and in 1955, the Spitzholter valve or shunt was invented, and this shunt increased the survival rate of Spina Bifida from 10% to 80%, which is a huge difference. But with this shunt came other complications like bladder issues and renal failure. And so in the 1970s, some doctors questioned if patients with Spina Bifida should be treated because their quality of life was not really good. And Dr. John Lorber especially questioned if patients with Spina Bifida and their complications or complications of failure would even be happy at any point in life. And luckily for people with Spina Bifida now, other doctors did go through with new developments, and recently the MOUNTS trial was set up, and there was a trial for fetal surgery on Spina Bifida, and fetal surgery has a lot of advantages compared to post-natal surgery.
Yeah, so I'm going to talk a little bit about the treatment for spina bifida. And some of these, such as ventricular peritoneal shunting, and some that I'll get into later, ETV, deal with hydrocephalus. So there are 3 postnatal or neonatal surgeries that deal with Spina Bifida, and 3-ish that are for or in. And I'll get into it. So the first is ventricular peritoneal shunting, and Meryl talked a little bit about this, but there's a tube that's inserted into the ventricles of the brain to reduce the fluid, and it's kind of a plasticky material, and it goes and it lets the fluid, cerebrospinal fluid, drain to the abdominal cavity and the heart cavity, or the pericardium. And the reason why these two cavities are membranes, which allow them to resorb fluid at a higher capacity. So the other surgical approach that deals with hydrocephalus, endoscopic third ventriculostomy, or and choroid plexus cautery. And these are actually two different procedures, but they're often kind of put in the same surgery because they coincide. So ETV basically is when there's a blockage in the cerebral aqueduct in this part of the brain. So it permits the spinal fluid, cerebrospinal fluid, from flowing out into the rest of the brain and upward, which causes a lot of sweat. Kiana mentioned during. And so basically the surgery just opens up this aqueduct and allows it to flow a little bit. So the next one is the traditional removal of sutural surgery. So here I have all these different types of spina bifida that Casey has. And so depending on the types, it's going to require different sutural surgery and different meninges that are going to be sutured up. So for example, this one we can see here. This one we can see that the dura mater is going to, once you remove the myelomeningocele sac, which is shown right here, you can suture up this dura mater, and the subarachnoid space is closed by suturing up the arachnoid. So prenatal surgical approaches, or surgical approaches, was actually really researched by MOMS, or MOMS, which is highly ironic, but at the same time, they're a really great organization that looked into the ethical approaches operating on. So they pretty much determined that this prenatal surgery aspect was much better than postnatal surgery because it caused a lot of, it prevented a lot of issues for fetus. It reduced hydrocephalus, risk of hydrocephalus, so that lowers the possibility of the shunting and procedures. Okay, so basically endoscopy or hysteroscopy is just a simple way of getting an idea of how things are looking in the uterus as far as and it's basically just an endoscope into the canal and being able to visualize what for diagnostics and some surgeries, which I'll talk about a little bit. So the open technique is something that was historically very prevalent for surgery of spina bifida because it was basically very simple, laparoscopy of the hypogastric of the mother. And basically they would make an incision on the mom for the fetus and go through the placenta and turn the fetus onto its back so that it exposed the sac. And then the traditional sutural approach was applied where they would remove the myelomeningocele sac and then repair the spinal meninges that had been disrupted. This caused a lot of issues because historically they didn't really have the technology and the cleanliness to really make it so that there were no infections, and it risked a lot for the mother because there was a massive, it was a huge incision, so that was likely to get, infected, and later if they needed to have a C-section, it had to be opened again, and there was a lot of issues just making this large of an incision. So the newest and most successful approach is the laparoscopy hysterectomy, and this involves kind of a combination of the open technique and endoscopy, in which there's several small incisions that occur within the hypogastric region of the abdomen, and for the tools, and then there's a hysteroscopy also inserted. So the hysteroscopy allows for an extra lens to see the uterus and be able to operate with little visual idea of not having to open up a huge gap in the stomach which has a lot of
So as we have talked about, there has been a very long and complicated history of spina bifida that has gone hundreds of years now. There have been a lot of trials and tribulations, but as of now, patients who are born with spina bifida today are in a much better place than they once were. As you can see here, those born who received fetal surgery are doing much better, have a much higher success rate in their lives